All right, there I am. So I may have a few technical issues here. I hope they will be minimal, but wanted to get started. It's right at 6:31 here Central Standard Time. Wanted to welcome you to the Haynes Method Neuromuscular Dry Needling. This is Module 1 or Lecture 1 of our entire it's 32 hours of lecture. Fortunately, tonight is just 2 hours. Tonight will comprise the introductory material. So I wanted to go ahead and jump straight into that. Let me bring this up so that I can see. Very good. I'm going to minimize that. All right. So lecture number 1, again, is the introduction to dry needling. My name is Dr. Luke Haynes. I'm a physical therapist. I'm certified in the Haynes method of dry needling and actually 2 other certifications in different methods. Over the past 7, 8, 9 years, I've been developing this particular method of dry needling. I've looked at different approaches and used some of their methods, but ultimately I found that with my patients that I've treated, that the approach that I've developed, I got much better outcomes and much more tolerable to the patient themselves. So I'm going to go ahead and just jump right in. If you have questions, feel free to shoot them into the chat, or if you're doing this offline on demand, feel free to send me a message through any of my handles, and I'll respond to that. So as I mentioned, this is the introductory piece. If you're watching this seminar asynchronously, or if you're watching it on demand and you're taking the course for CCU credit and ultimate certification, which means you're going to participate in the lab sessions as well, which there are 4 total lab sessions. It is required that you submit your homework assignments as well to get your full credit and proof of attendance. And then the assignments, you'll find those at the end of each lecture. If you've signed on here, you'll have access to the student portal. And in there, you will also have the homework assignments listed, as well as some other information that might be helpful as far as for some videos. There's access to the app, the Haynes Method app, that gives you all of the dry needling locations and as well for all the muscles, tendons, ligaments, perineural protocols, and diagnosis-specific protocols. So again, assignments you'll find there at the end of the lecture and on the student portal itself. The Haynes Method Neuromuscular Dry Needling. This is what I'm calling a hybrid DN certification course. It's a 64-hour dry needling certification presented in a hybrid context, with 32 hours being live, synchronous virtual lecture, and the other 32 hours being live in-person lab sessions. These lectures are also recorded so that they can also be taken on demand. The lecture will be broken into 16 2-hour lectures. Tonight is lecture number 1. They'll occur every 2 to 3 weeks on Tuesdays, and they're going to be from 6:30 to 8:30 Central Standard Time. We will have an introductory 8-hour in-person dry needling lab that is optional unless you're going for certification. That will occur after the first 4 lectures, and then the advanced in-person dry needling lab is in a very intensive 3-day, 24-hour lab session that will occur after the final 16th lecture. Those participants who have successfully completed the entire course and wish to demonstrate advanced clinical competency can sit for both a written and practical exam, which upon successful completion will lead to certification in a Haynes Method of Neuromuscular Dry Needling certification. First 4 lectures in the first lab comprise the introductory course in the Haynes Method of Neuromuscular Dry Needling. This lays the groundwork for advanced protocols that will be taught in the remainder of the lecture, lab, and subsequent certification. The introductory material discusses the history of dry needling, physiology, needle safety, indications and contraindications, and the danger zones of dry needling. A comprehensive review of current literature and best evidence will be discussed, as well as anatomy review using a 3D application that can be utilized prior to the course for review of the relevant anatomy. And this will also be used in later courses for protocol description. It's critical to competence and confidence with dry needling will be functional surface anatomy, palpation labs in each body region. Upon successful completion of the course, the participant will have the skills in place to return to the clinic the next day and implement the dry needling concepts that were taught during the course. Our course objectives: upon completion of the course, participants will be able to define dry needling and differentiate between dry needling and acupuncture, identify the appropriate patient population and conditions that may benefit from dry needling. Number 3, demonstrate proficiency and competence with needle application and safe needle technique for the patient and the practitioner. 4, identify the appropriate dosing of dry needling necessary to treat an acute, subacute, or chronic neuromuscular dysfunction. 5, describe the indications, precautions, and contraindications of dry needling. 6, discuss the locations and anatomical structures in the danger zones of dry needling to ensure patient safety. Number 7, discuss the current best evidence related to dry needling. Number 8, describe the level of proficiency needed by the PTA or any assistant to satisfy the PT or other provider requirements to perform dry needling under the provider's supervisor, and what areas are not appropriate for the assistant. And number 9, identify specific treatment rationales and protocols for various diagnoses in body regions. The coursework was developed as I was beginning to train and teach my own staff. I do have assistants that I employ in my clinics. And so that was where we started out with the PTA. It can easily apply to any other profession that is appropriate for dry needling and who also utilizes an assistant of some type. Haynes method is a unique approach to dry needling developed after practicing using both the trigger point and an acupuncture method in over 50,000 patient encounters using dry needling. HMDN was developed after applying the most common treatment approaches in dry needling and learning which aspects were effective and which were not. Dry needling is not and should not be used as a standalone treatment. In fact, dry needling is simply a tool used to decrease pain, inflammation, or neuromuscular dysfunction to a level that will make the remainder of the subject's treatment more tolerable and more likely to achieve successful outcomes. Dry needling should almost always also include some form of manual therapy to restore motion, strength, and return to prior function. HMDN is not a philosophy based upon trigger point therapy, meridians, or chi. It's based upon the concept of identification of focal points or points of inflammation in a movement system, and is subsequently using the needles to stimulate the body's own inflammatory responses to reverse the course of the dysfunction. Might that include trigger point? It might. However, is it actually possible to identify a focal point between two clinicians and have empirical evidence to support where that location is? That answer is specifically no. Looking at the charts developed by Travell, we know that there is a large variance in trigger point locations. Further, traditional theory would have a clinician repeatedly piston the needle until a twitch response is gained. My patients have never been a fan of that, and you as the student involved in the lab sessions would not enjoy that either. Therein lies a component of poor outcomes based on patient refusal of further treatment. More on the philosophy, it's based upon the 3 phases of healing. Our phase 1 goals are going to be to control pain and inflammation and prevent loss of motion. Our phase 2 goals, we're going to restore normal motion and restore normal strength. And then finally, our phase 3 goals are to maximize motion and strength and to prevent re-injury, prevent future pain, and just get back to life. Dry needling is almost always limited to use during phase 1. During this initial phase, assessment will be needed to be focused not solely on the pain. More to the point of the goal of assessment should be on finding the focal point of inflammation in a movement system. Furthermore, rarely is successful dry needling treatment limited to single muscles. There will always be strength and flexibility issues and other components of the movement system that will be required to be addressed in order to give the patient a maximal probability of restoring that system back to normal. For example, a patient presenting with knee pain should be evaluated to determine the following: which specific components of the knee are tender and painful? Is there ligamentous or tendinopathy involved? Are they tender to palpation? Are they more tender during active or passive movement? Is the pain leading to restricted motion and strength? are the other structures involved in the system? Are those structures demonstrating inflammation locally or proximally or distally? Are the movement systems affected proximally or distally? Is there a neurological impairment from the spine? And is there a neurological impairment distally, such as an entrapment, or compression? The evaluation is very dynamic based upon the responses from each movement system and will need to be reassessed at each follow-up treatment session. Additionally, returning your patient back to normal is based upon giving them a direct approach to managing their symptoms. As you identify and treat the focal points of inflammation, the patient should be assigned work to do at home, flexibility of the target tissues. That's for inflammation reduction, and then strengthening, which is for restoration of function. Without stating the obvious, it is critical for the practitioner to be skilled at identification of landmarks and structures of the human body. It would be impossible to needle target structures without being able to precisely identify them and differentiate them from other structures. A 3D anatomy application, therefore, is critical to relearning the relevant structures. HMDN is presented as follows. 1, the general concepts of dry needling. Then we move to how to dry needle specific introductory muscles. After that, how to dry needle the complex muscles, the tendons, the ligaments, and at the nerves. Then we'll move to specific diagnosis-related dry needling protocols, and then we'll have specific perineural dry needling protocols as well. Finally, HMDN is based on the concept that learning never stops. The principles learned in this course will give the certified practitioner an advanced level of skill and knowledge to implement dry needling into their practice. As you become more skilled in the technique and the response of the subjects to its application, you will be able to modify the techniques to adapt to the responses you see. Human body is a larger scope of knowledge than we will ever conquer, however, and new techniques are frequently being developed. Ongoing research needs to be reevaluated, in my opinion. The majority of research being conducted is based on outdated trigger point theory and not on movement systems. Furthermore, the actual needle locations are rarely included in research. That is a failure, for how can the research be duplicated if we're unable to use precise locations in treatment? HMDN provides specific landmarks, distances, and depths to improve upon standardization of the technique. The history of dry needling, modern dry needling, has its roots from the work of Dr. Janet Travell and Simmons in her book, Myofascial Pain and Dysfunction, the 2-volume red book, Trigger Point Manual. She uses the term dry needling to differentiate between the use of a hypodermic needle for treatment in one method with an injectate and in the other method, no injectate or dry. She is notable for coming up with the term trigger point or myofascial trigger point and the treatment of trigger points with needling, either wet or dry. Her artwork from that book have no doubt been part of the education process for any clinician studying muscle dysfunction. Although dry needling originally utilized only hypodermic needles due to the concern that solid needles had neither the strength or tactile feedback that hypodermic needles provided, and that the needle could be deflected by dense contraction knots, those concerns have proven unfounded, and many healthcare practitioners who perform dry needling have found that the acupuncture needles not only provide better tactile feedback, but also penetrate the dense muscle knots better and are easier to manage and cause less discomfort to patients. Further on the history, traditional Chinese acupuncture dates to about 100 years BCE, although there have been instruments found that are thought to have been used as acupuncture tools dating back as far as 6000 BCE. It is explained as a technique that can balance the flow of qi, your energy or your life force, which is described as flowing through meridians throughout the body. Western medicine dry needling places no impact on the concept of qi or meridians in treatment. It is true that there is occasionally some correlation between traditional Chinese acupoints. The key differentiation between dry needling and TCM is the why and where of needle placement. So a few graphs that demonstrate some of the pieces of traditional Chinese medicine. You see the lines running from the head, the upper body, down to the leg, from the arm and down. And these are the different meridians of the body. And this is not an all-inclusive view. If you've ever looked a little bit closer into acupuncture, you'll know that there's lots of them here. They demonstrate the yin superficial meridians on the left, and on the right it demonstrates the musculature. For the arm, it demonstrates the lung meridian, the heart meridian, the liver meridian, the spleen, kidney, and the pericardium meridian. On the right, it demonstrates the large intestine, the small intestine meridians, what's called the triple warmer, the stomach meridian, the bladder meridian, the gallbladder meridian, and then finally there's what's called the governing vessel. So Western dry needling, we don't base anything on traditional Chinese medicine or acupoints. That being said, I don't discount their method. I have many patients who've tried acupuncture with varying degrees of success. I'm not educated well enough to be able to effectively apply their approaches. So again, big differences in the how and the why of placing needles. As another example, this is for dry needling in and around the knee. As you can tell, the acupuncturist is using spleen, kidney, stomach, large intestine, gallbladder, a lot of specific lines specific to meridians, and including large intestine 4, even in the hand. And so that's one of the biggest issues, is that why they're trying to where they're needling. Again, their objective is to alter the flow, increase or decrease of the qi in that meridian. Interestingly, for a patient with knee osteoarthritis, there may be a lot of these same points that we needle in and around the knee and the lateral compartment here on the lateral side. Here you see, and even on the medial aspect, a lot of those issues have some correlation. But why we're placing them and where, we're not looking at specific meridians. We're looking at specific anatomical structures that we want to needle. Likewise, here's a picture of an auriculotherapy chart. A lot of people have a lot of belief in the auriculotherapy, and again, I'm not going to discount it. It's just not a piece that I teach or that I place a lot of emphasis on, simply because that approach is to address qi in the meridian, and that's, again, not what we do. More modern times, the American Physical Therapy Association defines dry needling as a technique physical therapists use where it's allowed by state law for the treatment of pain and movement impairments. Technique uses a dry needle, one without medication or injection, inserted through the skin into areas of the muscle. Other terms commonly used to describe dry needling include trigger point dry needling and intramuscular manual therapy. Again, dry needling is not acupuncture, a practice based on traditional Chinese medicine and performed by acupuncturists, but dry needling is a part of modern Western medicine principles and supported by research. So research is ongoing concerning the physiology surrounding the response to dry needling. I've listed a number of articles down below. A lot of these have some really good information in them. Generally speaking, it is agreed that dry needling will increase blood flow in the area where we needle. It'll decrease the taut muscle banding and the tenderness or sensitivity associated with them. It can decrease the spontaneous electrical activity or the twitch response, although some research suggests that may not be relevant for successful outcomes in dry needling. And there's also central nervous system and biochemical changes that can occur, suggesting that there are local changes, but also more distal and proximal changes as well. And there's a study by Shaw, I think it's that 2008, that discusses that in more detail. So on the physiology, why are we dry needling and why does it work? If you're taking this course, odds are at one point in time, you or somebody that you know has been dry needled and they were extremely impressed with the outcomes, made a huge difference. So why are we needling? Why does it work? What's causing the pain and tenderness is one of the biggest questions. Is it the taut bands in the muscle, which can be palpated, and they're identified as the point of pain and tenderness. The top bands can be thought of as a low-grade, persistent muscle contraction or cramp. So why does that muscle stay contracted? So first off, let's explore that mechanism of muscle contraction. We'll look at three different pieces, one at the neuromuscular junction, at the skeletal muscle, that of skeletal muscle contraction itself, and then the basic mechanisms of musculoskeletal pain. So in the neuromuscular junction, that refers to the synapse between the motor neuron and the skeletal muscle fiber. Activity at the neuromuscular junction is essential for the contraction of skeletal muscle to occur and even to keep muscles from atrophying. When a motor neuron approaches a muscle, it branches out into several extensions that in an area called synaptic boutons, which can release neurotransmitters. And these synaptic boutons are situated over specialized region of the muscle called the end plate. The synaptic boutons are also separated from the end plate by a space called the synaptic cleft. The end plate between each synaptic bouton contains several deep indentations called junctional folds. And these junctional folds contain high numbers of ligand-gated ion channel receptors for the neurotransmitter acetylcholine. So when an action potential travels down a motor neuron, it causes the release of acetylcholine into the synaptic cleft. Acetylcholine binds to the acetylcholine receptors in the junctional folds of the muscle membrane, which then causes ion channels to open to allow positive sodium ions to flow into the postsynaptic cell. This produces a depolarization of that cell called an excitatory postsynaptic potential, also known as the end plate potential, when it occurs at the neuromuscular junction. This depolarization leads to the opening of voltage-gated sodium channels, which causes the end plate potential to lead to an action potential. And this action potential travels along the muscle fiber and causes contraction of the muscle. Then the enzyme acetylcholinesterase is also present at the neuromuscular junction. It breaks down acetylcholine and in the process terminates its effects on the muscle fiber, thus in the communication between the motor neuron and the muscle fiber. Okay, so that's the neuromuscular junction. Let's look at skeletal muscle contraction. Skeletal muscles are composed of bundles of muscle fibers. These fibers are long cylindrical cells containing several nuclei. The muscles will contract or relax when they receive signals from the nervous system or the neuromuscular junction. The neuromuscular junction is the site of this exchange. This is where the synaptic bulb of an axon terminal and a muscle fiber connect. Muscle fibers are then composed of many myofibrils. Myofibril contains contractile units called the sarcomeres. Sarcomeres run adjacent to one another down the length of the myofibril. Each sarcomere consists of alternating thick and thin protein filaments, giving skeletal muscle its striated appearance. The muscle contracts when these filaments slide past each other. Muscle fibers are also composed of many myofibrils. Okay, that's in there twice. So again, let's look a little bit closer. We break down the skeletal muscle. We have the thick filaments, which are myosin, and they're anchored at the center of the sarcomere called the M line. In the middle, we have the thin filaments, which are composed of the protein actin, which are anchored to the Z lines at the outer edges of the sarcomere. Because the actin filaments are anchored to the Z lines, the sarcomere shortens from both sides when the actin filaments slide along the myosin filaments. And so now let's look at a little bit closer in depth here. Although the action between filaments is described as sliding, the myosin filament actually pulls the actin filament along its length. The cross bridges of the myosin filaments attach to the actin filaments and exert force on them to move. This action is known as the sliding filament mechanism of muscle contraction. In this model, the sarcomeres shorten without the thick or thin filaments changing in length. This causes the myosin head, let me start over. A contraction begins when a bound ATP or adenosine triphosphate is hydrolyzed to ADP or adenosine diphosphate and an inorganic phosphate. This causes the myosin head to extend and attach to a binding site on actin, forming a cross bridge. An action called the power stroke is triggered, allowing myosin to pull the actin toward the M line, thereby shortening the sarcomere. ADP and inorganic phosphate are released during the power stroke. The myosin remains attached to the actin until a new molecule of ATP binds, freeing the myosin to either go through another cycle of binding and more contraction or to remain unattached to allow the muscle to relax. And just a neat little video that I ran across that demonstrates that. And that is not it. Let's try a different one. Bear with me. I'm going to find the right one. There it is. So we see the myosin and the actin creating the cross bridges, and in so doing, shortening that sarcomere. But the process itself begins, if it'll catch up. So here we have ATP present. It splits into ADP plus another phosphate. When that happens, it's going to then reach up and bind and pull and thereby shorten. It then releases, but it's going to stay bound until another ATP comes and attaches. When that happens, it releases, it can split again, and then continue that process. And this happens very rapidly. So there's a lot of biochemical action that's taking place to make this happen. All right, let me come back now to I have lost my PowerPoint. All right, let me open that back up. Bear with me. All right, now let's share again. All right. Okay, so then we move into even further in depth. The muscle contractions are controlled by the actions of calcium. The thin actin filaments are associated with regulatory proteins called troponin and tropomyosin. When a muscle is relaxed, tropomyosin blocks the cross bridge binding sites on actin. When the calcium ion levels are high enough and ATP is present, calcium ions bind to the troponin, which displaces tropomyosin, exposing the myosin binding sites on actin. This allows the myosin to attach to a binding site on actin, forming a cross bridge. The calcium ions are stored in the sarcoplasmic reticulum and are released in response to signals from the nervous system to contract. Neurotransmitter molecules are released from a neuron and bind to receptors, which depolarizes the membrane of the muscle fiber. The electrical impulse travels down the T tubules and open the calcium stores. The calcium ions flow to the myofibrils where they trigger a muscle contraction. As the actin and myosin slide along each other, the entire sarcomere shortens as the Z lines draw closer to the M line. As the sarcomeres and myofibrils contract, the entire muscle fiber will shorten. When muscle fibers contract in unison, a muscle can produce enough force to move the body. So let's now talk about the basic mechanisms of musculoskeletal pain. Myofascial trigger points are common cause of non-articular musculoskeletal pain. They are a discrete, palpable, hyperirritable nodule in a taut band of skeletal muscle that can only be diagnosed by systematic palpation of the soft tissue. Activation of group 3 and 4 nociceptive afferents cause the pain and tenderness experienced at the motor trigger points. One mechanism of musculoskeletal pain is initiated when noxious stimuli deform the axonal membrane of the muscle nociceptor endings beyond their firing threshold, causing the release of a variety of biochemicals such as bradykinin, prostaglandins, and serotonin from muscle tissue, which may stimulate group 3 and 4 muscle fibers. This biochemical cascade can also be elicited without mechanical trauma to the muscle. Once sensitized, the group 4 afferents fire at lower thresholds, responding to innocuous stimuli like weak pressure and muscle movement, causing the exquisite tenderness of active trigger points. The phenomenon is called peripheral sensitization. Continuous input from myofascial trigger points can increase excitability of dorsal horn neurons. This phenomenon is called central sensitization. This can cause allodynia, hyperalgesia, and open previously ineffective synapses, resulting in new receptive fields and the referral of pain. There are also stored substances and nociceptor endings also affect microcirculation through vasodilation and plasma extravasation. The nociceptive input from skeletal muscle is much more effective at inducing neuroplastic changes in the spinal cord than input from the skin. This dynamic process can fundamentally alter pain threshold, pain intensity, and emotional affect. So all of that physiology that we discussed. So what then is responsible for that muscular pain we are treating? Is it the traditional trigger point theory? ATP releases actin-myosin cross bridge. Is the ATP insufficient to allow for the release of the cross bridge and thereby maintaining the low-grade spasm or contraction that we can palpate? Or acetylcholinesterase, which unbinds acetylcholine at the neuromuscular junction. Is ACH remaining bound at the NMJ, thereby maintaining a constant depolarized state, allowing for ongoing spasm or contraction? So which is at fault for continued contraction? Is it the Golgi tendon organ? Is it centrally mediated? Is there a locking at the spinal segment that's creating aberrant conductivity to the neuromuscular junction? There's lots of theories, and in all honesty, it may be some of all that contribute. As we look at the theory of pain and pain research of the past 50, 75 years, there's still not a great clarity or uniformity of thought in what is causing pain and what is causing these things to take place. So you have to keep an open mind, and it could be a little bit of everything. So let's talk on and move on to needle safety. So that physiology is the bulk of what you're going to get, other than anatomy. So gloves. There's an ongoing debate among the different schools of thought concerning the use of gloves. Acupuncture associations discuss the loss of dexterity with gloves and the inability of gloves to prevent needle stick injury. However, it is always recommended to use universal precautions and use gloves anytime there is a risk of exposure to bloodborne pathogens. As far as skin prep, patient's skin should be clean and free of any contaminants. It is a clean environment. It's not a sterile environment. The area to be treated can be cleansed with an alcohol swab or pad. 70% isopropyl will do the job, and allowed to dry for 10 seconds prior to treatment. You definitely want to let that alcohol dry before you drive it into the skin with a needle. Needle disposal. Needles are used only once, except in very rare occasions. Needle tips will dull, as you can see in that picture above. After more than one usage, especially if there's any periosteal pecking was performed, obviously it should not be reused. You want to have an appropriately sized sharps disposal container in the immediate vicinity, and dispose of needles immediately after removal from the patient. And word of caution, do not overfill the sharps containers. Handling needles. The best practice dictates that the shaft of the needle should not be touched with the bare skin or with untreated gloves. When using longer needles, it can be necessary to use the fingers of the non-needling hand to keep the part of the needle penetrating the skin to keep it oriented in the plane desired. To guide the shaft of the needle, the glove should be used and cleansed with isopropyl alcohol to allow them to dry prior to touching the shaft of the needle. Concerning resheathing, caution should definitely be taken when reusing a needle. To resheath the needle into the guide tube, turn the needle with the handle facing down and block the end of your ring finger. Insert the handle into the guide tube and allow at least 5 millimeters of handle to exit the guide tube. We'll use the index finger to hold the needle and guide tube unit stationary, making sure the sharp end of the needle does not extend beyond the guide tube. So I say that's an awful lot of words, and I'll have a little demonstration video. And if you go to lab, we'll practice and demonstrate that well. A lot of that depends on one, if you're resheathing, but two, the type of needle, the manufacturer of the needle that you happen to be using. So let's move on to indications and contraindications. The contraindications, the number one, lack of clinician competence in dry needling. If a person takes an introductory dry needling course, or you yourself, if you just watch this video or go through all 4 introductory lectures, or even if you go through all 16, but you've never dry needled before and you've never had any lab experience, if you haven't had supervised experience and exposure to dry needling, that indicates that there's just not the clinical competence to do it. So you definitely want to avoid that if the competence is not there. Another important one is non-consent from the patient. If there's a patient that you really feel would benefit from dry needling, it's certainly fine to talk to them about the benefits, the pros and cons of dry needling, what you would expect would have happened to them. But if they just don't seem to be interested, or they just have too strong of a phobia over needles, then consider that non-consent and move on to another treatment modality. We'll discuss first trimester of pregnancy in more detail in a bit. Contraindications, again, the nipples, the umbilicus, external genitalia. If a person has got uncontrolled anticoagulant usage, if there's a problem with a compromised immune system, if there is a local infection or an active tumor, or if you're dry needling into the occipital or suboccipital region of a patient with a Chiari malformation, and in an area over a pacemaker or defibrillator or in any sort of implanted electronic device, and also the rib cage without advanced training. So some relative contraindications for our post-surgical patients. Generally speaking, 6 weeks wait on dry needling, 6 weeks with any communicating tissue, and then 12 weeks within the local area. Also, relative autoimmune diseases, history, a person with a history of lymph node removal. They may have lymphedema, which we'll talk about, person with respiratory illness. Those are relative. Have I dry needled people very recently after surgery? Absolutely. But that's only with consent and permission from the patient, and specifically from the surgeon involved in the case. Some precautions, again, needle aversion or phobia. If there's a significant cognitive impairment, communication barrier, a history of traumatic or spontaneous pneumothorax, if they have severe hyperalgesia or allodynia, if they have a metal allergy, it's not common, but some people do have that allergy to metal, or if they have an abnormal bleeding tendency or some sort of significant vascular disease. Additional precautions, if you're needling into the pectorals or any area around the breast, if they are a candidate, a person that has a breast implant or any sort of augmentation, you want to definitely be significantly aware and have a deep conversation with your patient about those. Patient that's had a laminectomy. Frequently when we dry needle in the spine, especially for multifidus, we are using the lamina of the vertebra themselves as our backdrop. And so if they've had a laminectomy, obviously they are now without lamina. And so we have to use special precautions in that situation. Similar, a person with scoliosis or severe osteoporosis, we may just not be fully aware, 100% sure of where that structure is that we're using for our backdrop. So additional precaution in that regard as well. Some potential complications. This, according to an article published in 2001. It's a little bit old, but it's a very good study by White. Here, what they're describing is common issues. One, needle insertion pain. And this may be due to numerous factors, such as slow or an inadequate initial tap of the needle. We could have hit a small cutaneous nerve fiber. And honestly, that's impossible to avoid at all times. Or a small vessel was pierced. Another is muscle soreness, and this can occur and is expected to last for 1 or 2 days post needling. So always indicate to a patient that most people the next day have a significant reduction in the inflammation in their symptoms. But some people have as many as 3 days of some fairly significant soreness as a result. Either one that happens is not abnormal. It's just different response from different people. You can also have fatigue. You want to encourage rest and plenty of fluids post needling. Some light activity might be appropriate, but I certainly wouldn't dry needle and have someone go do vigorous sport that afternoon. Bruising. They may be sore and bruised for a varying length of time if a vessel or vein is needled. Caution, as a hematoma may cause increased soreness of the tissues. If that happens, have them use ice and compression if there's a hematoma present, and then just communicate your aftercare instructions to your patient. Probably, I don't have hard numbers on this, but maybe 1 in 15 to 20 needles, you may have a little bit of a blood droplet that comes out when you retract the needle. It happens. You just want to let your patient know ahead of time that can be a complication. If it does, you just apply a little bit of pressure with a cotton ball and the bleeding will stop. At that point, you do want to let them know that odds are you will have a bruise in that area, probably a dime-sized bruise in the area of the needle that produced a little droplet of blood. More uncommon, and this is 0.1 to 1%, soreness. Well, they can have aggravation of symptoms. Soreness from needling is common, but it should not simply exacerbate the current symptoms. If this happens, the therapist should really reflect upon the treatment, and it's discussed further in reasons for ineffective dry needling, and make the appropriate modifications. You may also feel faint or dizzy. This says 0.1 up to 1%. I would say that my experience more recently is that may be more in the area of maybe 1 in 25 has a small episode of dizziness with initial session of dry needling, but we'll talk about that more in just a little bit. And then lastly, if there's a stuck or a bent needle, it's very uncommon, and it is associated with an aggressive muscle contraction secondary to a local twitch response or a patient contraction. To alleviate that, just relax and wait. You can use an electrical stem on the needle if necessary. You can change pressure with the palpation hand, or perhaps insert an adjacent needle. But it does happen. I've had it happen to me as a patient. My history is I have, and I 50,000. I've probably 50,000 patients. I've probably close to 500,000 needle insertions at this point, and I've had 0 needles break. I've had maybe 10 have gone through the bent situation. Just retract the needle slowly, and it will come out. In a worst case scenario, if a needle does break, you apply a little bit of extra pressure and either pull the needle out with your fingertips, or always have a pair of hemostats handy just to grasp onto it if that were to happen. Rare, very rare infection. Reduce the likelihood of it by adhering to clean needle technique and universal precautions. In my time using just a clean technique, of the vast numbers that I've done, I've been exposed to 0 cases of infection related to dry needling. Pneumothorax, this is the big one. This is the significant concern when needling over the rib cage. There are natural variations in lung fields, which will increase the risk of pneumothorax. Areas of concern and conditions to consider include the lower lobes extending down as far as L2, patients suffering from COPD or emphysema, where the lung tissue may protrude in the intercostal space. We'll talk about the danger zones in a second, but even the upper lobes, as they can potentially extend even above the first rib. So dealing with the upper traps, you want to make sure that you have your angle correctly, which we'll walk you through that. And then lastly, they list the vasovagal reaction of less than 0.01%. Again, my experience is that vasovagal reaction is tied to the dizziness response. And again, maybe 1 in 20, 25 has this sort of response. And normally it's very mild. It's just a sense of of unease, of dizziness, and it passes. A patient, when this happens, again, retract the needle. The patient should quickly recover by placing them in a supine position, feet raised. Prevent additional consequences from this type of incident. Treatment should always be conducted with the patient laying down. In our next module or chapter, we'll begin our introductory dry needling itself. And for the introductory phase, all of the dry needling positions are in either the supine, sideline, or prone position. And that is simply to alleviate any concern that may happen if a patient does experience a vasovagal response and becomes lightheaded. I have had several patients actually faint, have a syncopal episode during dry needling. One reason to stay close to your patient when you're dry needling, and again, ideally have them in a recumbent position so that if they do lose consciousness or ability to remain vertical, that they're in a protected space to begin with. So let's move on to our danger zones. Several locations in the body that require even the experienced dry needler to take caution due to the proximity of body organs, nerves, and blood vessels. This course, our initial introductory course, Foundations and Fundamentals, is designed so that the structures being taught and needled will minimize the risk of the more potentially problematic areas. With that being stated, there's always potential for complications in even the most basic dry needling protocols if the clinician performs the techniques away from the established procedures outlined and taught in this course. The danger zones themselves, we'll go through them one at a time. The atlas axis, the upper cervical region, here we want to be cautious because of the spinal cord, cerebellar tonsils, spinal ganglia, and nerve roots. The vertebral artery is there, and the deep cervical vein. Person with Chiari, several of the suboccipital muscles are very close to the foramen magnum. We do dry needle them. We do it in a safe and appropriate technique as long as the technique is followed. So definitely indicates that you need to perform a good history and exam prior to needling in that area to rule out any sort of Chiari or issue in that area. The supraclavicular triangle. Here we have the brachiocephalic trunk, the subclavian artery, the common carotid artery, the axillary artery, the brachiocephalic vein, internal and external jugular vein, the subclavian vein, axillary vein, brachial plexus, apex of lung. Obviously, there's a lot of stuff that happens here. So from an introductory standpoint, when needling, most common thing I would see there is the upper trap and maybe the sternocleidomastoid. And we do walk you through how to do this. You want to make sure that you respect that supraclavicular triangle. Now, that being said, there's still a lot of needling that takes place in that anterior aspect of the cervical spine in the neck. So just from an introductory level, great respect, well, even in advanced, great respect for that supraclavicular triangle. In the thoracic spine and the rib cage, again, I don't recommend introductory level at all needling onto the rib cage. And the majority of people who are dry needling, if you never get past an introductory course, I strongly encourage you to stay off of the ribs. It's easy to think that we have a good feel for where the ribs actually are, but it can be misleading. And in that area, we have our cardiopulmonary viscera and the lungs, and that's not a place for a needle. That being said, the lamina of the thoracic spine provide a really nice backdrop for needling into the multifidus and the muscles in that area. At the iliac crest, there are some things that we end up needling in that area. We'll get to that in the advanced level of the coursework, but obviously there's quite a bit of contents in that area by the iliac crest that we want to be cognizant of so that we don't drop a needle into any of the viscera. At the TL, the junction down to L2, this is an area of the vertebra where our lamina but get very narrow. So as we progress into this course, we'll talk specifically how to dry needle into the spine, what landmarks to use, how to go about that. But great respect has to be given in this TL junction that those lamina are getting more narrow and that you have to respect that area even more. Again, the lower lobes of the lungs, we have the diaphragm in that area, and in the kidneys as well. In the femoral triangle, here we have the femoral nerve, the femoral artery and vein, the external iliac artery and vein, and the suprainguinal viscera. So the muscles that comprise this femoral triangle, we want to respect those elements, especially femoral artery. But that's not to say that we don't needle things in this area. There's a lot of important things in the groin that we will needle. Again, initially starting in the introductory piece, we stay out of there. At the sacral, the coccyx, the buttock region, our biggest issue there is the sciatic nerve, the rectum, superior and inferior gluteal arteries and veins. When we get into needling piriformis in the introductory piece, we're going to needle it out laterally at its attachment onto the femur. In the advanced coursework, we will move into the area right off the sacral border. We just have to be cautious with our depth so that we don't needle down into that sciatic nerve. And there's a technique that you'll learn that's very easy to find the true depth of the osseous structure and then move laterally and advance just a little bit more to get the muscle without risk to the sciatic nerve. In the cubital fossa, here we've got the brachial artery, the basilic vein, brachial veins, and the median cubital vein, as well as the median nerve. We go to the popliteal fossa, obviously a lot in there, the femoral artery, popliteal artery, and vein, the small saphenous vein, and then our tibial nerve and our common fibular nerve. So there's really not a whole lot of reason that we need to be in that specific area. However, we do get right outside of that. So we'll demonstrate and show you how to needle the things in and around the posterior aspect of the knee without risking that central neurovascular bundle. So more on dizziness and lightheadedness. Initial dry needling session should be performed in prone or supine in the event that symptom occurs. It's thought to be a vasovagal response, and it should pass shortly. It can include a feeling of nausea, vomiting, and diaphoresis. And it can be complicated with the patient being overly anxious, tired, or fatigued with dehydration or lack of food. This response typically only happens in the first session and is not repeated. Feigning can occur if the response is severe enough so that the prone or supine position or side lying is the safest for the patient. In that event, remove the needles immediately and have the patient remain supine with feet elevated until the symptoms are gone. On the topic of pregnancy, there's no noted connection between dry needling and miscarriage or other pregnancy complications in any of the 3 trimesters of pregnancy. The most common trimester for miscarriage is the first, so there is a potential medical legal reason to avoid dry needling during the first trimester. Because of the potential adverse reactions that can accompany dry needling, it is important to treat with a minimal approach. Reduce the number of needles used, minimize needle manipulation, and decrease the time the needles remain in situ. As with standard contraindications with electrical stimulation, it should be avoided during pregnancy. Lastly, some post-surgical lymphedema, definitely contraindicated to dry needle into a site with post-surgical lymphedema. And a patient who has had mastectomy should not be needled distal to the site of the lymph node removal. Conversation about supervision, in this case, PT for PTA, it can apply to any provider who is authorized by their Practice Act to needle and who utilize assistants. Practice of physical therapy or any other provider-assistant relationship often involves a multi-staff approach to treatment that may involve more than one PT or may involve a PTA or more than one. In a perfect scenario, it is ideal for the same clinician to remain the only clinician treating that patient throughout the patient's course of treatment. That scenario is not always possible or even practical. clinicians call in sick or go on vacation or move on to other job opportunities. The patient still needs to be treated and their care managed in a consistent manner. That is just as much the case when dry needling is included, if not more, in the treatment plan. It is incumbent upon each physical therapist to gain proper training and competence in dry needling before practicing the techniques on patients. It's even more incumbent on the examining or supervising physical therapist to ensure clinical competence of the subordinate treating clinicians that they, one, have the clinical competence to perform dry needling in a safe and effective method, and two, that the subordinate treating clinician has the training and approach that the supervising clinician has prescribed in their treatment plan for that patient. Specifically, the supervising clinician should establish specific treatment parameters based on defined protocols that both clinicians have demonstrated competency. The subordinate clinician will have the ability to withhold treatment, but not modify or add to the established treatment protocol based on the patient's condition. If there were adverse events that took place in one of the needling locations, such as bruising, increased soreness, etc., then it would be permissible for the clinician to modify or delete that treatment point. But communication between the patient and the treating clinician and the treating and supervising clinician is of the utmost importance in the PT-PTA treatment relationship when utilizing dry needling as a treatment modality. It would not be appropriate for a supervising PT to allow a PTA to alter the treatment protocol, except for withholding certain treatment locations due to adverse events, without discussing the case with the supervising PT first, and only then with approval of the supervising PT. If the treating PT is on site, it would be ideal to discuss the adverse event with the PT prior to treatment to discuss other options. At a minimum, the PTA should discuss the adverse event with the supervising PT before the patient returns for follow-up treatment. The PT-PTA team is responsible first to ensure no harm to the patient, and second, to utilize the dry needling protocols taught to the most effective benefit of the patient. From a legal standpoint, and I'm not an attorney, and I don't pretend to be one, but inadequate supervision on the part of the PT would make the PT potentially liable for any adverse event that occurred due to negligent acts on part of the PTA. Negligent acts could include ignoring established danger zones and contraindications established as part of training, as well as altering the established treatment protocol without documented consultation with the PT. The Haynes method of neuromuscular dry needling is structured to teach its students the safety aspect of dry needling, but to also teach specific treatment protocols that establishes the structure necessarily within the PT-PTA or provider and assistant relationship for the supervising clinician to establish the treatment protocol or protocols to be implemented, and the assurance that upon completion of the certification process, the PTA would be clinically competent to carry out the dry needling protocols that are part of the plan of treatment, and would further ensure communication between the clinicians that is vital to proper execution of the dry needling protocols. On our manual palpation skills lab, surface anatomy is key. It's vital. It's incredibly important for the determination of the proper location of needle placement. Each surface anatomy lab session will be conducted prior to the dry needling lab. And so just for a brief review of our planes of the body, because we will reference these throughout the course. Our dorsal, ventral, cranial, caudal, sagittal, transverse, frontal. Definitely want to be aware of those. If not, you want to brush up as you study through this course and whichever 3D anatomy product you choose to study with. So some dry needling considerations. Needle placement location is determined with the first consideration for safety to avoid the danger zones, and the second consideration for the maximal therapeutic effect. Needle location is frequently determined as a certain number of finger or thumb breadths from anatomical structures identified in the palpation labs. When referring to a finger or thumb breadths distance, remember that the distance of measure is based on the finger or thumb breadth of the patient, not of the clinician. I'm 6'3", and I've got a big frame. If I used my digits as reference points on a 5-foot, 100-pound person, my distances would be very off. So in doing so, look at your patient, your subject, and use their finger breadths to determine proper distances. When needling on the spine, almost every time we use the spinous process as a reference. And when we use that reference point, and you can see it in that little picture, it's there's a, it's going to say green, it's some green aqua looking color over the spinous process. The spinous process itself is circled in pink, and then that upper lateral aspect, superiormost aspect of that spinous process, that is where we start our finger breadths to move laterally, either 1 or 2. In most cases, just a single finger breadth. In areas where there's a palpable bony linear surface, such as the spinous process of the spine or the tibia or the spine of the scapula, the tips of the fingers can be used to hook over the bony landmarks, and we do that on a few occasions. Here, when we're inserting a needle, number one, determine the desired needle placement location. We're going to use the index and middle fingers, and here we're going to apply some firm pressure to splay the fingers apart to tighten the skin at the point of needle insertion. When we apply the needle, then we're going to rapidly tap the handle of the needle that extends beyond the insertion tube to quickly depress the needle through the outermost layers of the skin. We'll then remove and dispose of the application tube, grasp the handle of the needle in preparation of advancing the needle in with a desired angulation and depth, with or without backdrop. So the importance of splaying the fingers and tightening that skin, it decreases the amount of resistance that needle is going to face as it enters into the skin. And the quicker that you're going to tap the needle, apply that, and get it through the surface of the skin, the less discomfort your patient's going to experience. That splay finger method can also be useful in bracketing. In this example, I'm bracketing the brachioradialis, and that's frequently helpful in identifying specific muscle groups. Needle manipulation. So needle manipulation can be very effective in a number of instances, and we'll discuss that as we get in to our protocols. In situations where there is a contraindication to dry needle to electrical stimulation, I may more than likely I'm going to perform some sort of needle manipulation in that process to facilitate the response that I'm looking for. With that, it can be an effective tool to elicit spontaneous electrical activity or the twitch response. Or it's also known as the do chi sensation by the acupuncturist. Different types of needle manipulation. One is pistoning, and this is probably the most common method taught in Western medicine. Pistoning is most frequently performed in muscles that are more inclined to demonstrate that twitch response or the spontaneous electrical activity when they're needled. Those people that advocate pistoning postulate that the trigger point or the MTRP should be repeatedly needled or pistoned until that twitch response is no longer present to gain the maximal therapeutic benefit. I will say now, and I will say throughout the level of the course, I'm not an advocate of pistoning as a general rule. There are cases where it is appropriate, but as a general rule that every thing that we needle needs to be pistoned, that is not my position. That can be create excessive soreness in your subject, and it can also be, quite honestly, simulated through the application of electrical stimulation to elicit that same benefit. In my opinion, it produces a better benefit in that regard. Bidirectional rotation is another way of eliciting a change. You leave the needle in the same location and simply between the thumb index finger, rotate the needle back and forth 90 to 180 degrees or more at about 2 hertz or 2 cycles per second to elicit that response if that's what you're looking for. It also is a nice way to introduce or force the body to stimulate an inflammatory response, which is ultimately what we're looking for in order to get the body to fight the aberrant activity that's happening again at the neuromuscular junction, at the motor end plate, at the myofascial, the sarcomere itself. Again, we don't know why it's happening. We just know that it is. And if we can elicit an inflammatory response to the needle in that tissue, then it will release. Unidirectional rotation can be very helpful. It can be performed between the thumb and the index finger in a single direction. In most tissue, after 2 to 5 seconds, the tissue collagen will wind around the needle, becoming stiffer with rotation. A person with a higher concentration of adipose tissue or in a body region traditionally that will have more adipose tissue, it may take a little bit longer of rotation to have the collagen wind around that needle. This procedure can be used to elicit the SAE or Do Chi sensation, but it can also be used in a tenting maneuver to mobilize that underlying tissue in a direction in the same plane as the needle. We frequently use this with people demonstrating problems with tenosynovitis, areas where we're looking for that response out of other connective tissue, tendons, ligaments, meniscus. Those are a nice place for a little unidirectional rotation for tenting. In terms of pistoning, care should be taken with pistoning bidirectional and unidirectional rotation to be aware of the depth of the needle that you've determined to be the most therapeutic for the patient, and use the remaining exposed needle as a depth gauge to avoid needling into a danger zone or beyond the depth that you intended. Some grips that we frequently use. One is the lumbrical grip. Here the fingers flex at the MCPs while keeping the PIPs and DIPs in full extension, and the tissue is grasped between the flattened fingers and the thumb. The profundus grip, MCPs and PIPs remain in the extension, and then the DIPs are flexed to hook around the target tissue. In the pincher grip, target tissue is just grasped between thumb and index finger and compressed. So another critical component in refining your ability to target specific target tissues is needle redirection. The redirection involves using the splay technique demonstrated in that picture and maintaining that pressure while inserting the needle to the desired depth. If, as the clinician, you feel you could place the needle in a more therapeutic location, you have the option of removing the needle and inserting another, or you can perform a simple redirection technique. To redirect proximally or towards yourself, retract the needle until only about 1 centimeter of the needle remains in the tissue, and then use your splay fingers to push the upper tissue and the skin away from you, and the needle will orient in a trajectory back toward you. To redirect distally, it'll be the opposite. Retract the needle until only about 1 centimeter of the needle remains in the tissue. Use your splay fingers to pull the upper tissue and skin toward you, and the needle will orient in a trajectory away from you. You hold the tension on the skin and advance the needle. Redirection is very frequently used. It's much easier in our smaller tissues. Say we get into muscles in the feet, in the hands, in the face. We really don't want to, once we've got the needle in, we really don't want to have to take it out and put it back in. So a simple act of redirection can be very helpful. And we should have a video that talks about that. And then if you participate in the lab, we'll demonstrate, and you'll have a chance to practice that in lab as well. And so this is where we get to our lab demonstration on the peach and the apple. We've just talked about our grips, and then we'll look at some needle manipulation. So here, with a little luck, let me come back and change my share. So I'm using a Mac, and normally I work everything off of a PC. So it gets a little confusing for me sometimes. Let's see here. So I want to share. All right, let me go open that. All right. And where did that go? There it goes. All right. So a little demonstration here, and I'm going to switch again to this. All right, let me stop the share. All right. So I've kind of demonstrated the hook, the splay, the bracket, the grips. Let's talk about the peach and the apple and the needle manipulation. So I always like to use a peach because a peach has a nice pit. Plum can be used as well. Unfortunately, apparently this isn't peach and plum season. So I've pulled out an apple. So as part of your homework, the first thing we talked about is I wanted you to work a little bit on resheathing a needle, just using the needle, manipulating it. Another thing I want you to work on, and I just want you to shoot a short little video of using an apple to insert your needle. So it's really important. Number one, we want to, if this were skin, I would want to splay and bracket and create some nice tightness on this skin. As we place the tube down, one thing that's really important is that we put enough pressure. So if you don't place that needle down and give it a little extra pressure, and so for me, I'm going to come in and let's see, orientation. So I'm going to take, I've got the needle pulled away. The needle is nowhere near my skin, but the guide tube is. I've created depression in my skin. And that extra pressure on the guide tube also gives you a little bit more surface tension, or it takes away a little bit more surface tension to make it easier to advance that needle through that skin. So on your apple, you have to be careful because if you push too hard on your apple, you're going to push through the apple. So I want you to simulate pressing, making good contact on that apple. And then the real challenge is in a rapid tap onto the top of that needle. And then you can pull it out. And then from there, you just want to advance that needle in. An apple will have some piece of a core in there, so you'll get there and you will feel it hit in there. Most of the needling that we do look for a bony backdrop. And so that is a nice simulation of a backdrop. If it's a small apple, be careful on the other side. With regular human skin, as the needle approximates the exit point of the needle, we will feel pressure on the apple that's just going to come through and poke you in the finger. So be aware of your needle length. So that's number one, is just getting some good practice on resheathing, dropping, and advancing the needle. There are lots of ways of doing the tap, depending on the location. I tend to do just a tap with the end of my index finger. I'll keep my finger bent at the joints. It can also be done with a straight finger. Either way like that. It can be done a third way, and that's with a thumb on the other side. Like such. So the other thing that we talked about a little bit was the needle manipulation. So we come in, we get a nice, whatever our target structure is, we get it there. Let's say I'm a trigger point. Let's say I want to go get a trigger point, and I insert my needle, and I don't get that magical twitch out of the muscle that I'm hoping for. So what I can do is what they refer to as the pistoning, and I can just reposition that. Now, unfortunately, in the apple, I can't really move the needle around and really change its orientation. But that is, pistoning is just moving up and down, trying to hit more of that tissue at one time. I rarely do this, simply because I don't want it done to me, and research tells us that we don't have to be this traumatic to our tissue in order to elicit the response that we don't. But most of your motor trigger point theory is based on pistoning. The second approach is unidirectional and bidirectional rotation. So bidirectional rotation, again, between the thumb and index finger at about 2 hertz. I'm just going to rotate it right there. It sounds odd, but you can get a good response from the patient, you can start to get that muscle contraction, which is that crampy, achy sensation that we're looking for. So we can get that. And then the third, which is the unidirectional rotation, and I'm just winding this in a single direction. I can wind, now it's not going to an apple, but in a collagen-based human, that tissue will start to wrap around that needle. And then it will get tight almost to the point where you really can't move it any further. From there, I can then tent that tissue and pull it away from the body and mobilize that specific muscle deep to the body and get a very good response there. So, again, as far as the homework, we want to look at needle manipulation, or resheathing, I should say. Again, just practicing dropping the needle in. See? So I'm just going to drop it in. That way I'm ready to needle there. We want to look at the actual needle penetration, a very rapid application. And then we want to look at pistoning, bidirectional rotation, and then unidirectional rotation. That's the extent of it. Since we're here, I also wanted to demonstrate different needle sizes that we have. So this needle is 5 centimeters or 50 millimeters in length. It is 0.3 millimeters in diameter. That's fairly standard. We have a smaller needle, which is, this is 2 centimeters. There's some that I use that are 1.5. I don't really use anything shorter than 1.5. 2 centimeters, I think you can see that adequately. 2 centimeters, let's move up a little bit. Let's go, no, there. And here. And my most common needle that I use is probably a 6 centimeter. But depending on the location, we have also up to a 12.5 centimeter. And so you can see a big difference in length of needle. Each of these needles are the same diameter. So with this large one we talked earlier, you can see it's a much longer handle. If I try to advance this needle into this, I'm going to come back up here, into this apple with my tube. I can get it here, but if I try to advance it, you can see that needle is just going to bend. And so with my gloved hand, I can then assist that needle in. So, and yes, there are times when we need a much longer needle. We'll talk about when we get to that, when that would be necessary. Okay, so electrically stimulated dry needling, it is extremely rare for me not to advocate the use of electrical stimulation applied directly to the needles themselves. Again, for me, this is a nice way to elicit that spontaneous electrical activity or that twitch response or the Do-Chi response by using electrical stimulation. We also, with that, can bring in, we'll talk about just briefly in a second, our gate control theory, our TENS approach to pain management. But a study here by Kimura, and this study, oxygen dynamics in muscle tissue was improved after using NRS after electrical acupuncture at 20 hertz, and the oxygen supply to muscle tissue did not change significantly with it at 1 hertz. Thus, the frequency of 20 hertz is recommended for muscle fatigue and in muscle pain and acupuncture treatment in order to perform electrical acupuncture to facilitate the blood flow and oxygen supply in affected muscles. Stimulus conditions, including duration, waveform, should be further investigated in the future. In this study by Leon Hernandez, pins Application after dry needling treatment is more effective than dry needling alone for decreasing soreness in the short term and improving neck pain intensity immediately in patients with myofascial chronic neck pain. Here they used 2 to 5 hertz and a pulse width of 120 applied over a 15-minute period. I can tell you more often in clinic, a variation of this is what I'm going to use, a combination of 2 to 5 hertz. I probably stay closer to 3, quite honestly. And as we get further, I'll talk a little bit more about when and how I apply electrical stim to our patients. We have the gate control theory, the TENS approach, Melchak and Wall 65 published the gate control theory with which increased the use of electroanalgesia. This theory hypothesized that activity in small diameter nerve fibers causes pain, and that by stimulating the larger diameter sensory nerve fibers, the perception of pain is reduced. They proposed that a physiological gating mechanism exists in the dorsal horn of the spinal cord, and this gate can be opened or closed to allow or inhibit the transmission of painful stimuli through it and up to the brain where it is processed. By selectively exciting A beta nerve fibers in the skin with TENS, the amount of painful stimulation being transmitted by smaller diameter nerve fibers can be reduced through segmental inhibition. So we have high frequency, low frequency, or burst TENS. A high frequency or conventional TENS is anywhere from 90 to 130 hertz. This causes the pain gate to close by stimulating the small A beta sensory nerve fibers. Conventional TENS also acts by reducing the release of excitatory neurotransmitters such as aspartate, glutamate, increasing the release of inhibitory neurotransmitters such as gamma aminobutyric acid, the GABA, and serotonin. In the low frequency or the acupuncture TENS, which is in the 2 to 5 hertz range, low frequency TENS, known as acupuncture TENS, has a low pulse rate. It acts by stimulating the A delta fibers to produce endorphins, which in turn relieve pain. And then there's burst TENS. Burst TENS stimulates both the A beta and the A delta nerve types at the same time. In the burst mode, conventional or high frequency TENS is regularly interrupted by 2 to 3 bursts of lower frequency TENS. Their different programs can be used interchangeably according to the preference of the patient. Length of pain relief in low frequency TENS tends to take longer time to achieve analgesia. Since the analgesia produced by the application of low frequency TENS is due to the release of endogenous opioids, it lasts for a longer period of time. High frequency TENS or conventional TENS has a quick onset of analgesia, but loses its effect quite rapidly when turning off the stimulation. The post-treatment analgesic effects of TENS can thus last anywhere between 5 minutes to 18 hours. It's been reported that in some patients, pain levels do not return to pre-stimulation levels even after 24 hours. So post-stimulation analgesia has been widely attributed to the accumulation or depletion of endogenous opioids. There's a wide variation in post-treatment pain relief experienced by patients, and no reason for this has been documented yet. Chang et al. Reported a cumulative effect in pain reduction after repeated applications of TENS and suggested that the mechanisms underlying this may be related to changes in the neuronal pathway. Breaks between sessions and/or changing electrode positions is essential, as with long-term use, the nervous system becomes habituated to TENS, causing poor pain control. So my approach: the use of electrical stimulation with dry needling is clinically advised at low frequency at 2 to 5 hertz for patient tolerance and stimulation of the spontaneous electrical activity or twitch response. So when I see a patient for the first time, number one, I want to determine what our protocol is going to be. What are we going to be dry needling? The next thing is I want to determine how they tolerate dry needling itself. And then lastly, I want to determine how they respond to direct to the needle or electroacupuncture, electro dry needling. And so in that case, I use a specific handheld unit that I stimulate those needles at a low frequency, 2 to 5 hertz, usually closer to 3, for a period of 10 to 20 seconds. And in that initial session, that's all the electrical stimulation that I'm going to get. And I do that so that upon their return, I can determine if the electrical stimulation applied to the needles was an effective tool, or if it didn't seem to give them a big change in their symptoms. And then finally, a note concerning recommended needle length. Actually, before we do that, on our recommended initial treatment, our follow-up treatment, especially if it's a more chronic problem, what I frequently recommend is more the burst approach. In that approach, we get a mixture of both the high frequency and the low frequency. Depending on the unit that you use, the units that I use have a burst setting that every 3 to 4 seconds, it's going to go from a low frequency that we set to a high frequency that we set. And those frequencies can fluctuate from 2 to 3 hertz up to 20 on up to 100 hertz. With the intensities that we're talking about, the higher frequency is not always tolerated. So if the intensity is low enough, you can do a 2 to 100 hertz frequency, and that's recommended. Depending on the patient's tolerance, you may have to drop that intensity down to around 20. And so that's, again, for your more chronic patient. And then finally, a note concerning recommended needle length. A patient's body habitus can drastically change the length of needle required to reach target depth to ensure a maximal therapeutic response. Each protocol that I teach will have documented safe needle length for the introductory piece. You will needle some patients within a recommended BMI, and some that are way off the chart. The recommendations in this manual are designed to ensure safety in most every adult patient population. As you become more skilled in the techniques taught in this course, you'll discover that with a larger body habitus, you will be required to use varying needle lengths different from those taught in this course. No one body is the same. The needle lengths recommended here will ensure a safe beginning down the road of mastering dry needling. And so let's talk about dosage and frequency. I frequently asked, well, how do I determine how much needling and how often should it be done? How many sessions? And it depends, but I've created a basic outline of the patient according to certain parameters, and let's talk about that. So how do you determine dosage and frequency? Most cases can be divided into 5 categories. The dosage and frequency is determined on their activity level, the chronicity of the condition, their response to treatment, and probably the most important factor is the compliance of a patient to a well-developed home exercise program. I'm a massive believer in dry needling as a treatment modality to address the first phase of healing. That being said, it is only a modality and it is not the cure. And the belief that it is the cure is just false. Dry needling is needed, as is any other modality, to address a neuromuscular response to a biomechanical dysfunction. That dysfunction can only be addressed through a change in mechanical function, flexibility, and strength. When properly applied, dry needling can be the most effective tool we have in our arsenal to address phase 1 of healing, which is the inflammatory response. So our categories: number 1 is the athlete. Here, this person, they have no comorbidities. The issue is new. It's within the first 10 days of injury. They have not had a significant deviation from strength or performance level. Our frequency of dry needling here is going to be 1 to 3 sessions within 3 to 5 days. Their prognosis is excellent. They will be able to resume normal training within 2 to 4 days. If the athlete has one or more comorbidities, the issue is now moved into a subacute stage. They're 14 plus days out. They've begun to have some asymmetries in strength and performance. Here, the frequency of dry needling is going to be 3 to 6 sessions within 7 to 21 days or 1 to 3 weeks. Prognosis, again, is excellent. They'll need 2 to 3 weeks of training to restore asymmetries, and then they can resume their performance training. For the average Joe, which is just your weekend warrior, your everyday person walking around out there, they're in decent physical shape. They had some incident resulted in a strain or an overuse injury of a localized muscle or group of muscles. Here, frequency of dry needling is 1 to 3 sessions within 3 to 5 days. Again, prognosis here is excellent, but they will need to adopt an ongoing HEP to address the mechanical deficit to set them up for the injury. And success depends on completion of that home exercise program. Then we have the quick stick. This is your work colleague. This is somebody who slept wrong, so has a crick in their neck or they're down in their back, somebody that just needs a quick fix. The frequency of dry needling here, it's 1 single session. Prognosis, though, is just fair. They'll have an underlying condition that will need compliance with an HEP to correct, but they won't be willing to accept this fact or be willing to do the work. There's a decent chance this person will become the procrastinator. The procrastinator has 1 to 3 comorbidities, has been dealing with the pain and the function complaint for several years. They're unable or unwilling to deal with the issue due to a variety of valid or invalid reasons, and now have decided to do something about the problem. Frequency of dry needling here, it's going to be 8 to 12 sessions within 30 days. Prognosis is good, but success only depends on their compliance with the HEP. We can take these people, we can reduce their inflammation, but if we don't have them become compliant with their HEP to address their movement dysfunction, then their problem is going to return. So as a person that owns clinics, I guess you could consider that a good deal. However, when you're talking about success with your patients, they have to do that at HEP, and then they'll have their success. And then finally is the hard case. Here, there are multiple comorbidities. Say there's severe OA or DJD, other issues that require surgical intervention or other intervention that cannot be done due to medical or personal issues. They can't get cleared for surgery due to pulmonary or cardiac issues. Here, our frequency of dry needling is going to be 8 to 12 sessions for the first 30 days. The second 30 days is going to be 4 to 8 sessions. And the 30 days and beyond that is going to be 2 to 4 sessions. Prognosis here is fair. This is long-term maintenance case. Insurance may be an issue and require cash pay. Treatment will be required until interventional clearance is obtained. This is non-pharmacological pain management. The dosage may have to be adjusted based on the patient's condition. Treatment should improve functional outcomes, but withdrawing or discharging the service will result in a return to prior condition. And there will be limited improvement with a progressive HEP. Again, I look at this, like I said, this is non-pharmacological pain management. The pain management docs, once their interventional procedures have stopped working, their patients get on that lifetime plan of narcotics and opioids. I like the idea of patients who still get the relief, but they get it without the added effect of medications. A lot of the protocols that we've developed are specific to dealing with this sort of a problem. I've got a patient that has now been in this program for probably 4 to 5 years. Her situation, she has a special needs. Now she's late 60s. She has special needs child. He's mid 40s. And both knees are bad. She really needs knee surgery. Right knee is worse than the left, but she has no other caregiver to care for her son, and she cannot be away for the amount of time that it would take to deal with that. So in her case, we did start out full normal plan of care, trying to work through strength, motion. After progressing her down for the last several years or more, have been just simply seeing her about once every, I think we're about once every 6 to 8 weeks right now. I see her for a single session. We'll get to it when we get to the advanced knee module, but I developed a specific genicular nerve protocol designed after the pain management injection technique for genicular nerves, and it'll buy her 6 to 8 weeks at a time on one treatment. That doesn't work with everybody. She believes in the program, and she wants to stay off pain meds and wants to avoid surgery absolutely as long as possible. And again, she's the hard case, non-pharm pain management. So that is basically the bulk of lecture number 1. And we're going to finish just a little bit early. Fantastic. Our next module, which I believe is in 2 weeks, number 2, we're going to jump into Introduction to Cervical and the Lumbar Spine. We'll talk a little bit more about supervision by PT and OT. Although we talked about it tonight, we may not end up talking about that again. We'll look at surface anatomy and 3D anatomy of the cervical and lumbar spine. We'll look at needle placement, location, description. We'll look at some supporting evidence, some clinical decision-making, and then we're going to get into our structures themselves. We'll look at, in the cervical spine, the splenius capitis surfaces, and the erector spinae, the spinalis surfaces, longissimus and iliocostalis surfaces, and semispinalis capitis surfaces, and multifidus. In the lumbosacral spine, we'll look at interspinalis lumborum, longissimus, and iliocostalis lumborum, as well as multifidus and the PSIS. 3D anatomy. I don't require you to go buy anything. I strongly, highly recommend that if you are engaging in pursuing dry needling, that you reacquaint yourself with functional human anatomy. The 3D programs that are out are cheap, and they are quite effective at helping you look at the body in 3 dimensions. As you are inserting needles into the body, you need to appreciate it and understand where all of the muscles, tendons, ligaments are, and the easiest ways to get to them. And using that 3D anatomy application is the best way to do that. I've listed several on here. And I've used most of these. I currently am using Complete Anatomy, the one up top. It's from 3D4 Medical. If you need more information about any of these, just yell and let me know. I've used most of these. Some of them are more expensive. There's some really high-end stuff out there, but it's not necessary. What you get out of these brands right here are plenty fine. So lastly, if you are planning on attending a lab session and you want to use this for CEU credit, then so that I have proof of your participation and attendance, you have to complete the post-lecture assignment. So number 1, you have to request to join a closed Facebook group called the Dry Needling Arena. Just go to Facebook and Google it. If you can't find it, let me know. I'll send you the link. So enter that arena. That is where all the clinicians enter their homework, and it's a great place just for conversation about things related to dry needling, things that work, things that don't. So three questions to be answered. 1, name 3 contraindications to dry needling. I want you to name 4 danger zones, and then what is one possible factor responsible for muscle tension and pain. And then lastly, I want you to take a short video of the peach apple, the needling and needle manipulation. I want you to take those, post all of that to Facebook. That closed group once you asked to join. For those who don't use Facebook, those things can be created and just emailed to me directly. So either way will work. I prefer in the arena so that more people can collaborate as needed. So that is the homework. Again, if you're watching this asynchronously and are taking the course for CCU credit, you have to remember to submit that homework so that you get full credit and proof of attendance. So we've completed lecture 1. I look forward to, and I'll have this, I'll probably go ahead and update the content that's on the website now in the student portal. So I look forward to doing that and then seeing each of you again for lecture 2, module 2 in 2 weeks.